Black women in the United States die from pregnancy-related causes at a rate 2.6 times higher than white women. Some peer-reviewed data places that number closer to 3. And I need you to understand something before we go any further. That gap does not close when you add money. It does not close when you add education. It does not close when you add the best hospital in the country. A black woman with a college degree, a 6-figure income, and private insurance still faces higher odds of dying in childbirth than a white woman without any of those things. That is not opinion. That is documented, published data from the Centers for Disease Control and Prevention. And that fact alone should tell you that the usual explanations are not enough. This is not purely about poverty. This is not purely about access. There is something deeper operating here. And today, I'm going to walk you through exactly what the science shows. Let me start with a name most of you already know: Serena Williams. One of the greatest athletes who has ever walked this earth. Trained her whole life, peak physical condition. In 2018, she gave birth to her daughter at a major hospital with top surgeons and world-class equipment. Hours after delivery, she began feeling short of breath. She had a known history of blood clots, and she knew her own body. She told the nurses exactly what she suspected was happening and asked immediately for a CT scan and blood thinners. She was dismissed. She had to argue for her own life before anyone finally listened. When they ran the scan, they found multiple blood clots in her lungs. She was right. She had been right from the beginning, and she came very close to not surviving that day. If Serena Williams, with all of her resources and all of her fame and all of her ability to demand attention, had to fight that hard to be believed, I want you to think carefully about what that says about what regular black women face every single day behind those closed hospital doors. Now let me take you into the actual science, because this story has a biological layer that most people are never told, and that silence is part of the problem. The first thing you need to understand is a condition called preeclampsia. Preeclampsia develops during pregnancy when blood pressure rises to dangerous levels and begins to damage organs: the kidneys, the liver, the brain. It can develop quickly. It can turn life-threatening in hours. Black women develop preeclampsia at significantly higher rates than white women. Research published in the American Journal of Obstetrics and Gynecology shows that black women are nearly twice as likely to develop the severe form of this condition. And when they do develop it, studies consistently show they are less likely to receive timely intervention. Now here is where the science goes even deeper, and this is what your doctor has very likely never discussed with you. There is a gene called apolipoprotein L1. Researchers call it APOL1. This gene sits on chromosome 22 and produces a protein involved in how your kidneys filter blood. Certain variants of this gene evolved in West Africa specifically as a defense against a parasitic disease called trypanosomiasis, which most people know as sleeping sickness. That parasite wiped out enormous numbers of people historically. The APOL1 variants that developed in response were extraordinarily effective protection. People who carry them are significantly more resistant to that disease than people who do not. That is a genuine biological advantage. Your ancestors survived because of it. But here is the part nobody explains. Those same high-risk APOL1 variants, when a person inherits 2 copies of them, are associated with elevated rates of kidney disease, elevated blood pressure, and a higher susceptibility to preeclampsia during pregnancy. Research estimates that approximately 13% of Black Americans carry 2 copies of these high-risk variants. That number is substantially higher than in white populations, where these variants are extremely rare. This is not a flaw in your biology. This is a genetic adaptation built for a specific environment, fighting a specific threat. But in the context of modern pregnancy, it creates a vulnerability that our medical system was not designed to recognize, because our medical system was never designed with you in mind. And here is exactly why that matters. The standard laboratory tools doctors use to evaluate kidney function during pregnancy were calibrated using research populations that were overwhelmingly white. The thresholds used to define what counts as dangerous were established based on those populations. That means a black woman can have early warning signs of kidney stress developing right in front of her care team, and her numbers still fall within what the textbook says is acceptable. The chart says safe. Her body is telling a different story, and no one in that room has been trained to hear the difference. That gap between what the numbers say and what is actually happening inside a black woman's body is costing lives. There is another layer here that the research is clear about, even though it makes people uncomfortable to discuss. It is called implicit bias, and it is measurable. Multiple peer-reviewed studies have documented that healthcare providers are statistically less likely to believe black patients when they report pain, less likely to follow up on symptoms that black patients describe, and more likely to underestimate the urgency of their concerns. A landmark study published in the Proceedings of the National Academy of Sciences found that a significant percentage of medical students and residents held demonstrably false beliefs about biological differences between black and white patients, including the belief that black people have a higher tolerance for pain. That belief has absolutely no scientific basis, but it directly influences treatment decisions. It influences who gets taken seriously when they say something is wrong. In a delivery room where the window between intervention and crisis can be measured in minutes, that bias is not just harmful, it is lethal. The Centers for Disease Control and Prevention estimates that approximately 60% of pregnancy-related deaths in this country are preventable. Not some of them, 60%. That means the majority of the women who died did not have to die. They died because something in the system failed to catch what was happening in time. The most common causes are hemorrhage, cardiomyopathy, which is disease of the heart muscle, and hypertensive disorders, including preeclampsia. Black women are disproportionately affected by all three, and in every category, delays in recognition and delays in treatment show up as a recurring factor. That delay is the gap, and that gap is wider for black women than for anyone else. Now I want to give you something practical, because awareness without action is just pain. If you are pregnant right now, or planning to become pregnant, or you have someone in your life who is, here is what I want you to do. Know your baseline before pregnancy, if at all possible. Get your blood pressure checked. Get a basic metabolic panel that includes kidney function markers. Get copies of those results and keep them. When prenatal care begins, you will have something to compare against. That comparison is powerful data. Once you are pregnant, monitor your blood pressure at home. You can buy a reliable upper arm blood pressure monitor for under $30 at most pharmacies. Preeclampsia frequently has no symptoms until it becomes severe. Tracking your numbers at home gives you an early warning system. If your readings start climbing, you do not wait for your next scheduled appointment. You call that same day. Ask your provider directly about preeclampsia. Ask what your specific risk factors are. Ask what warning signs to watch for at home. Ask what the plan is if your blood pressure rises. A provider who takes your care seriously will welcome that conversation. A provider who dismisses it is telling you something important about the level of attention you should expect from them. Bring someone with you to prenatal appointments, to the hospital, to every significant conversation with a provider. Not because you cannot advocate for yourself, you absolutely can, but because research has documented that patients who have an advocate physically present receive more thorough evaluations and more careful treatment. That should not be the case, but the data shows that it is. And if you are in a hospital and something feels wrong, do not leave without a real answer. Not reassurance, not vague comfort. If your body is telling you something is not right, say it out loud. Say it clearly, and say it more than once if you have to. Write down what you said and when. Ask for it to be documented. You are not being difficult. You are protecting your life. Everything I share with you here is for educational purposes. It does not replace the relationship with your personal physician. Please bring these conversations to your provider directly. Now I want to ask you to do something right now while this is fresh. If this video gave you something real, hit that like button and subscribe to this channel. I make these videos because this information should not require a medical degree to access. You deserve science that is built around your biology. And leave a comment below this video. Tell me whether you or a woman you love has ever been dismissed or not believed in a medical setting, during pregnancy or any other time. I read every single comment. Your stories help shape what I cover next, and they remind me why this work matters. I will close with this. The rate at which Black women die in childbirth in the richest country on earth is not an accident of nature. It is the accumulated result of a research system that excluded Black women for generations. A medical culture that inherited the biases of that system, and a pattern of care that has consistently treated Black women's pain and Black women's instincts as less credible than white women's. None of that is your destiny. Knowing what you know now is the first intervention. Sharing this video with someone who needs it could be the second. I am Dr. Marcus Webb, and this is the truth you deserve to know.